Some current issues. Let me go through some, just wander through some things, some current issues. Next slide. So this is pretty much what I think is the currently established, what I'd say evidentially based treatment for acute cluster headache is the high flow oxygen, delivered as best a percentage as you can. And there are a lot of issues around mask development that need to be done. I think that there hasn't been enough attention to that because either people were unconscious in an ICU with a tube down their throat, or they were sitting at home with airways disease. And the middle ground that you are is not really receive specific attention. I think that the gas guys have understood that and need to be thinking about masks that are designed for you, not just having to be picked up from the bloke with breathlessness down the road. That's an important development over time. You know that Imitrex sumatriptan 6 mg injections are effective for most people with acute cluster headache. They work quite quickly. There's only really one randomised placebo-controlled trial that's done. It's published in the New England Journal. So the FDA's got a history in cluster headache of taking one trial, which is interesting. Glaxo have not done it, as far as I know, or it would be nice to hear, a study with the 4 mg injector, because the reason that would be nice is trivial almost, but it's one of the reasons the sprays are used. If they did a study with the 4 mg auto injector, then they pick up safety data for 12 mg. They've already got safety data for 12 mg in 24 hours. And if they do a 4 mg study, then it would be easy to argue for 3 injections a day as opposed to 2 on a safety basis. And you and I both know that many of you totally ignore all rules concerning how many injections. A number of conversations I've had with that over the years. I never cease to be amazed. People who take like 6 injections in a day or something like that, and you think, Lordy God, what are they doing? And then they're fagging at the same time. Dear me, it's a strong group of people. Sumatriptan nasal spray I've shown you, and zolmitriptan nasal spray. So I tell my colleagues that these are the evidentially based things. I show them the placebo-controlled trials, and then of course warn them that there's about a PDR, rhubarb. But you know, reasonable people understand what the evidence is. Some patients use lidocaine or lignocaine in the nose. I don't think that's useful for most. The odd person finds it useful. It's difficult to blind sticking local anaesthetic in the nose because local anaesthetic in the nose. There's a study of cocaine that was used, or a different local anaesthetic. And again, cocaine, it's quite hard to blind cocaine, you have to realize, because it's got those funny little effects that people describe in the movies all the time. Next slide. I'm not going to go through everything that's used for preventive treatment. I just wanted to draw your attention to the Verapamil thing, which I guess most of you know. We've been trying to emphasise in the last year and a half or so with my colleagues so that things get done in a safe kind of way. Verapamil in cluster headache is used in what one could describe as industrial doses. It's much bigger than the heart doctors would use. They would typically use up to 240 milligrams a day, and we're using 960, so it's bigger doses. It turns out that produces a small problem with the heart rhythm. Next slide. You get constipation with those of you know that's pretty trivial. Some people get leg swelling, and there's this gingival hyperplasia. The gums get a bit swollen and they bleed. And, sometimes dental hygiene is the flossing and the rest of it will sort that out, and sometimes sometimes it means you have to stop the meds. The big problem is this heart business. Next one. What happens is that when you drive the dose up, it slows the way the pacemaker part of the cells communicate with the rest of the heart. And that's reflected in the cardiograms in that. This little elongation means that the time for the that's right, go right ahead. The time for turning the heart on from the little pacemaker area where the first little blip is to making the rest of the heart go slows down. And the problem with that is it can slow down so much that it goes into what's called complete heart block. And the heart goes very slowly, people putts out and they need pacemakers and all sorts of other exciting things. It turns out that about 20% of people with a cluster on high dose Verapamil will have that. We're typically dosing between 500 and 600 milligrams on average in this line. So, and the other unfortunate thing, which is a bit irritating, it's not understood at all, is that if you don't do anything on a high dose, it can happen even when things are stable. So on the right side of the panel is a chap who was stable on 960 with a normal, what's called PR interval. And when we saw him a year later, his PR interval had doubled into what's regarded as a dangerous range. So we recommend to doctors that the cardiograms be checked. You can't check them until about 10 days to 2 weeks after you change the dose, because it takes that long for the Verapamil effect to occur. And then you probably need to check them every 6 months. We don't really know whether it should be every 3 months. 6 months seems like a sensible rule. I'm happy to be told it's wrong. To make sure that the heart change is not happening for people who are on Verapamil in the long term. Next slide. Try to tell neurologists about that all the time, because it's not something they would have grown up with. I want to turn to the future. I've got a couple of questions. The first question I think that's really sticks out in my mind, and you must think about this a lot, and how common is the problem? Next slide.